Hello, everyone. Um, this is Masood. I'm one of the ST2s here at Norwich Academy. Um, so I'm going to talk about radiology subspecialties. I will just, there's a bit of heads up. This is a bit of a boring topic. I don't know why Phil gave me this one, but anyway. Um, so I'll just go through one by one. There are different subspecialties in radiology training, during radiology training. So I hope you guys are aware that initially in the first 3 years you rotate through all the modalities like GU, GI. At Norwich here we rotate 3 monthly in all those different modules, or what you call different blocks, like GU, GI, chest, neuro, IR. So in those 3 years, you also get an idea about your interest as well, what you want to do. As you can see it here, I've put it down different specialties: pediatric, MSK, vascular, neuroradiology, head and neck, GI, GU, etc. So these are the different like subspecialty which you can choose in during third year, and then in fourth and final years, obviously you mostly work in these subspecialties. Um, so then there's a question: how do you decide? This is a difficult question. There's no right or wrong answer. Um, some people just know like what they want to do. And to be fair, when you start your radiology, 90 to 95%, or maybe 80% people, they want to do IR. Like in my year, most of the people said they want to do IR. But as you rotate through different rotations or modules, I think your interest change as well. Like I personally like IR, and I have done my vascular rotation and I still like it. So I might go with the IR, but I still have many other rotations to do, like chest, neuro, and GU as well, and MSK, P. So I might like any other specialty. But so far, I've obviously decided that I want to do IR. But many people still don't um, uh, decide until the end of third year. So it's a difficult question. So as I said in the beginning, there's no right or wrong answer. Um, like as I said, often initial choice changes. Like many people wants to do IR, but at the towards the end of third year or the middle of third year, they have decided no, I want to do GI or GU. So obviously your preferences keep on changing. And then many people like working life. Some people don't want to do like on calls or nights when obviously they become a consultant. So if you work in DGS, you might not want to work as a pediatric radiologist because there might not be facilities there. So it's also depends on your working life and your personal interests as well. What do you want to do? Some people want to do private practice, so there are different specialties who's got better scope at private practice than other specialties. Like MSK has got good private practice scope, and then same is for IR as well. So it depends on your like personal choices as well. Some people want bit of hands-on, or they got a bit of surgical background, so they want to do a bit of intervention. For this purpose, intervention radiology is good. MSK is good. You do loads of intervention in MSK as well, and GI as well. You do liver biopsies and etc. etc. So it's basically it's a quite difficult question to answer. Um, it keeps on changing. Then there are a few quite popular specialities. I've listed just 4 or 5. Not popular, but the most popular one are MSK, GI, and neuro. And I said before, IR. Everybody wants to do IR at the beginning, but I think it keeps on changing uh, during mid training or towards the end of the training. There are a few most in demand specialties, which is like breast, vascular, IR, as I said before, head and neck, peds, and GU. But obviously, there are vacancies in all the subspecialties, and you end up getting this obviously subspecialty which you like. There might be more competition, but I think at the end, all everybody just gets whatever they want. I'll quickly go through each subspecialty in like a bit detail. So first of all is breast radiology. So in breast radiology, the good thing is there's no emergency scan. So like if you don't want to do anything overnight or anything emergency, you don't need to worry about that. Um, So most of the time it's just screening for symptomatic. Most of the, as you know, that in UK there's a breast screening program as well. So most of the people come for the screening purposes, and then there are obviously symptomatic as well, which gets referred from ED or a GP or from different specialties. And in that, obviously, in breast radiology, there are loads of patient contact because the patient are worried about uh, malignancy. Obviously, the young females who've got breast lumps. So it's a good specialty if you like patient contact, and if you're good at interpersonal communication skills. I think breast radiology is one of the best um, fields. And there's loads of intervention, as obviously you do biopsies, you do uh, much more intervention in breast radiology as well. And then comes the MSK. MSK is quite different in terms that there's a loads and loads of anatomy. Like obviously, if you look at thigh and lower leg, or there are loads of muscles, so you need to know your anatomy very well. And then it's multimodality as well. You do CT, MRI, fluoroscopy, ultrasound, and then loads of intervention. Like as I said, MSK has got good private practice scope as well. Many people do like we got consultants here who do loads of intervention like injections and many other procedures. And then again, there's quite a lot of patient contact as well. Like if you like patient contact, and then as I said, growth area, you can do private practice. It's got good scope of private practice as well. And then the next one I want to discuss is intervention radiology. Is again, as if someone has got a surgical background, or if they like wanted to be a surgeon but couldn't get into surgery, or they just like surgery. So this intervention radiology is a good choice for that. Yeah, lots of patient contact. Again, you do either vascular or neuro. They're different. Obviously, you have to choose one of these. A huge growth and demand, as I said, like in the UK, there are many people with aortic diseases. So it's obviously huge growth. You can do private practice as well. And the one thing in intervention radiology people don't understand is they think that they might be good at intervention only, but you have to be very good at general radiology as well, diagnostic radiology, because obviously you have to plan your surgery around CT scans and MRIs. So you have to be very good at your general radiology skills as well. And then with intervention radiology, obviously, it's more out of our work as well. When you are ST6 here in Norwich, so you do your nights as well, or you do on calls as well with a consultant. So and they're quite frequent because there are not many registrars here. So I think then on calls and nights they're quite frequent as compared with the general radiology, which is like one of my colleagues earlier explained is 1 in 16 to 1 in 20. So there's a lot of out of our work. But obviously, if you work in DGH, it's not that extensive or that bad. But here, obviously, if you're working at Norwich or a teaching hospital or tertiary hospital, it can be a bit demanding. It can be a bit challenging because there can be aortic rupture or aortic aneurysm, which is quite obviously 8 centimeter or 9 centimeter. It can be instantly picked up overnight scan. So you have to be aware that if you're working in a tertiary hospital or DG or a DGH, DGH might be a bit easier and relaxed, but tertiary might be a bit challenging, quite demanding. And then comes the peds. Again, peds obviously is for those who like kids, and obviously who are good with the kids. Loads of patient contact from NICU to teenager. And it's basically multimodality and system. You can do ultrasound, TT, and MRI. Because of kids, you don't want them to be exposed to lots of radiation. So basically, in peds, they try to rely much on ultrasound. Obviously, they go with the CT and MRI as well. But I think first modality of choice in pediatrics is ultrasound, because kids are thinner, they don't have much subcutaneous fat, so the ultrasound penetration is good. So I think that's why they go with that. And out of our commitment is one of those things in the peds as well. Like if you're working in tertiary hospital or like Norwich or teaching hospital, you there's a difference. There's a separate on-call pediatric consultant on call. This is separate to the general radiologist. So there's a ped consultant on call, and they can be called for any emergency like interception, and they have to come to the hospital. I think this is different in DGH. In DGH, you don't get these kind of emergencies. So if you're a pediatric consultant in DGH, you might be not that busy. But if you're working in tertiary hospital, tertiary care center like Norwich, you might get called for pediatric emergency overnight. And then obviously kids are great. Obviously, if you love them, Then there is quite a lot of medical legal aspect as well. Obviously, you can miss things. Yeah, that the parents can be not happy with your intervention. So there are many things which can cause medical legal issues as well. And then GI abdomen. So this is quite common. It's quite famous subspecialty here. It's a huge variety because it's such a big system. So many people choose to stick to either upper or lower GI. Some people do whole GI. We got vascular consultants here who do IR and then only HPB. So it depends on like what's your interest is and how much you want to take. Again, it's a multimodality. You do CT, MRI, ultrasound, and they also do endo-anal ultrasound. They do endoscopic ultrasound as well. And then obviously lots of scope of intervention as well, like you do liver biopsies, etc., etc. So it's a good specialty as well if you want to either go for the whole GI abdo, or you want to do upper GI, lower GI, or even you want to do only HPV that. So it depends on you. Or if you want to do something special, you can do like endoscopic ultrasound, which one of the GI consultant here does that as well, which I'm aware of. Again, neuro. It has limited patient contact. Obviously, you don't come in contact with these patients much, and it's loads of emerging modalities are coming in the neuro. All the new MRI sequences of this fancy scan, spectroscopy, all these come in play in neuro as well. MR is basically the workhouse, but it is used to be because in neuro you want to look for subtle things, subtle like TIA, subtle strokes, subtle space occupying lesions, or subtle changes. So all these are very good picked up at MR. And then opportunity to be very specialist as well. So you can do anything in neuro. You can't be subspecialized in neuro as well. So it depends on you as well. And in one thing which I forgot to mention in neuro is you have to know your anatomy because brain there's a lot of anatomy in brain. When you do the FRC part one, you will realize that to pass the exam, you don't need much of the brain anatomy to be aware of. Like I don't even know. I passed my exam, so it's still too much to know. And even if you are ST4, ST5, I think the brain anatomy is so complex. So there's a lot of anatomy to be aware of as an MSK. So that's one of the things to be considered in neuro. And then there comes the cardiothoracics as well. Obviously, you report all those cardiac MRIs, cardiac CT gated studies, and you are in close contact with a cardiologist. It's quite evolving specialty at the moment. It is quite different from the other specialties as well. You can combine with the other general or the subspecialty is a busy NHS work, especially after COVID. There are quite a lot of scans to be reported. There are not enough consultant who does the cardiothoracic. So it can be quite challenging and daunting as well. And then come the radionuclide or nuclear medicine. So it's basically in that case, obviously, when you read physics for FRC, you will understand. It's basically you put radiation inside the patient rather than giving a contrast to you. So it's a different kind of scan, and obviously you need to have a strong understanding of physiology in that. And obviously you can do multi-system, like scan the whole body. Obviously you have to go from the vertex top to the toes. And for some reason you need a specific set of license for that for operating this. So you get from the I think RCR or someone from different special certificate for that. And then the last one is the academic radiology. You can do ACF as well. This is basically 75% of clinical work and 25% research. So you basically can take at ST1 or ST3 levels. The main goal is to gain more academic experience prior to further academic training. And there's a huge scope for research in the academic radiology. So if you like something like research, so I think this is a good choice as well. And it can be quite competitive as well. And there are not enough posts for academic radiology. So this is one of the things which has to be kept in mind. If you're doing general radiology, you can still go into research, but obviously there's not structured program for that. And obviously you have to do quite a lot of things by yourself. But if you're doing ACS, obviously you've got a protected time for that, like 25% of your training. So obviously you can do research in a better way, or you can do academic work in much more protected way. And yeah, that's it. Thank you. These were the few subspecialties that I wanted to discuss. Again, obviously, as I said before, it's a bit too early to think about it. But obviously, some people just know that they want to do that subspecialty. Other people, they just want to go with the flow and decide later what they want to do. And there's no hard and fast rule to decide as well, and there's no pressure. So you can just start your training and then can decide along the way if you like any subspecialty in any way. That's it. Thank you. Any questions?